Hello everyone. Okay, so we have discussed our first unit, that is breast from systemic surgery. Now we will be discussing the thyroid. Okay, so what we will learn in the thyroid, we will be doing the uh, thyroid introduction, then the thyroglossal cyst, then the goiter or thyrotoxicosis, then hyperthyroidism or Graves' disease or toxic multinodular goiter, then thyroid tumors, then papillary carcinoma, follicular carcinoma, head and neck, acute parotiditis, pleomorphic adenoma, parotid carcinoma, carcinoma of tongue, and bronchial cyst. So, starting from the introduction of thyroid. Okay, thyroid is supplied by superior thyroid artery, inferior thyroid artery, and thyroid ima artery. Superior thyroid artery is from external carotid artery, inferior thyroid artery is from thyrocervical artery, and thyroid ima artery is from brachiocephalic trunk. Now, what is the synthesis of thyroid hormone? First of all, the trapping. The first step is trapping, then oxidation occur, then the binding, then the coupling, and then thus the thyroid hormones are formed. What are the investigations that are done for the thyroid disease? These are thyroid stimulating hormone is checked. That is, the normal level of thyroid stimulating hormone is 0.3 to 3.3, and if thyroid stimulating hormone is decreased, then thyrotoxicosis occur, and if thyroid stimulating hormone increase, then hypothyroidism occur. T3 and T4 level are checked for the investigations of thyroid diseases, which provides information about functional status of thyroid gland. Euthyroid normal functioning. In the normal functioning, there will be T3, T4, and TSH normal. In thyroid toxicosis, TSH will be decreased, T3 will increase, and T4 will increase. In hypothyroidism, TSH increase, T3 decrease, and T4 also decrease. In T3 toxicity, decrease or normal range of TSH and increase T3 and normal T4. Okay, thyroid autoantibodies are checked. These are antithyroid peroxidase, the antithyroglobulin, and thyroid receptor antibodies. Ultrasound scan is done to differentiate solid mass from cystic one. CT scan is done in case of suspected malignancy. Isotope scanning is done, and FNAC, that is fine needle aspiration, is done in case of discrete or solitary thyroid swelling. X-ray chest and thoracic inlet is done for the investigation of thyroid disease. So this was the general introduction of thyroid. We have studied that which arteries supply thyroid. These are superior thyroid artery, inferior thyroid artery, and thyroid ima artery. Then through which steps the synthesis of thyroid hormone occur. These are trapping, oxidation, binding, coupling, and secretion. Then investigation for thyroid diseases, we have thyroid stimulating hormone T3 and T4, thyroid autoantibodies, ultrasound scan, CT scan, isotope scanning, fine needle aspiration, X-ray chest, and thoracic inlet. Okay. Now coming towards thyroglossal cyst. What is thyroglossal cyst? It is irregular neck mass or lump developed from cells or tissues left over after formation of thyroid gland during developmental stages, and it is located below hyoid bone. It occurs anywhere along path of thyroglossal duct from base of tongue to suprasternal notch. Okay, thyroglossal duct. What is it? It is an irregular neck mass or lump which develop from the cells or tissues left over after formation of thyroid gland during developmental stages. It is located below the hyoid bone. Now, what are the clinical features of the thyroglossal cyst? These are midline swelling, and it moves upward with swallowing as well as protrusion of trunk. Unlike thyroid, which moves only with swelling, thyroid only moves with swelling, while the thyroglossal cyst move upward with swelling as well as protrusion of tongue. Now, what are the treatment options? These are cyst trunk operation, which include the removal of whole thyroglossal tract, which involves removal of body of hyoid bone up to the base of the trunk. Okay, now coming towards the goiter or thyrotoxicosis, we are having a scenario in which there is a 50-year-old 50-year-old male patient, and his multinodular goiter swelling in the neck is present. He lost 8 kg weight and bowel motion is loose. Then on examination, he is thin, tremors are present, heart rate is 110 per minute. Then neck smooth moderate enlargement. So what are the causes or classification of the goiter? These are simple goiter, that is euthyroid, also known as diffuse or multinodular goiter. Then toxic goiter, also known as hyperthyroidism. Then hypothyroidism. then neoplastic, and then inflammatory. In neoplastic, we are having the benign and malignant. In inflammatory, we are having autoimmune, granulomatous, bacterial, viral, and fibrosing, that is Riedl's thyroiditis. So these are the causes or different classification of the goiter or thyrotoxic causes. Now, what is hyperthyroidism? Hyperthyroidism is the overproduction of T3 and T4 hormones, and because of the feedback mechanism, serum TSH levels are reduced or um, undetectable. Okay. What is thyrotoxicosis? It is the excessive thyroid hormone. What are the common causes of hyperthyroidism? These are diffuse toxic, that is 70% Graves' disease, toxic multinodular goiter, and toxic nodules, that is adenoma. The rare causes of hyperthyroidism are thyrotoxicosis, fasciitis, job-based thyrotoxicosis, acute form of thyroiditis, secondary carcinoma, and neonatal thyrotoxicosis. Now, coming towards Graves' disease, what is Graves' disease? It is diffuse toxic goiter. Graves' disease is the most common cause of thyrotoxicosis. More than 70% cases is due to Graves' disease. Disease is autoimmune in nature and it is caused by abnormal production of thyroid stimulating hormone antibody. There are increased level of T3 and T4, thus leading to thyrotoxicosis. Simultaneous appearance of the goiter and is called primary thyrotoxicosis. Eye signs are more pronounced in it. In Graves' ophthalmology is present in Graves' disease. What are the treatment options? Above 45 years, radioactive iodine, and below 45 years, surgery is done. Now, what is toxic multinodular goiter? It occurs in older individuals with prior history of non-toxic multinodular goiter. Rare eye problems and common cardiac problems are present. Syndrome is called secondary thyrotoxicosis. What are the clinical features of toxic multinodular goiter and what are the symptoms? The symptoms are palpitation, that is heat intolerance, weight loss in spite of good appetite, increased appetite, insomnia, restlessness, diarrhea, and menstrual irregularities. Okay, these are the symptoms. The signs are tachycardia, that is hot, moist palm, exophthalmos, lid leg retraction, exaggerated reflexes, thyroid bruit, pretibial myxedema, cardiac arrhythmias, and fine rustic tremors. These are present in as signs of toxic multinodular goiter. What are the investigations that are done for the cases of toxic multinodular goiter? The T3 and T4 will be raised and the TSH is low. Thyroid skin is only indicated in case of nodularity and toxicity. It is useful to look at functionally active nodules. What are the treatment options for toxic multinodular goiter? These are medications are given. These are anti-thyroid medications. Radio ablation is done and surgery is done. Patient preparation for surgery, carbimazole, iodides, beta blockers, pre-op investigation is performed, fluid and electrolytes are corrected, and antibiotic prophylaxis is done. What are the complications? First complication is of anesthesia complication, then uncontrolled bleeding, then nerve injury, then cardiac injury, and then thyroid crisis. Okay, we are having these three broad classes of treatment, that is surgery, radioactive iodine, and antithyroid drugs. In surgery, radioactive iodine is given orally and taken by thyroid follicle. What are the advantages? This cure rapid and cure is high. While the disadvantages are that there is risk of hypothyroidism 5%, recurrence of laryngeal nerve injury can occur, and recurrence of thyrotoxicosis in case of subtotal thyroidectomy can occur. Okay. Now, radioactive iodine in toxic and nodular goiter surgery, subtotal or total thyroidectomy is done. What are the advantages? Is that it is not a surgical procedure and it is not prolonged drug treatment. While disadvantages is that it can cause late hypothyroidism. The anti-thyroid drugs that are used for the treatment of toxic multinodular goiter is carbimazole and propylthiouracil that are anti-thyroid drugs. Propranolol is used for cardiovascular effects, and carbimazole is given 10 mg TDS for 7 to 10 days, euthyroid 5 mg TDS or BD for 6 to 24 months. What are the advantages? That it is a non-surgical and no use of radioactive iodine. The disadvantages is that it's a prolonged treatment of 6 to 24 months. There is failure rate of 50%, aplastic anemia may occur, and oropharyngeal bacterial infection may develop due to antithyroid drugs. Now, what are the problems in the treatment of thyrotoxicosis? These are pregnancy, that is, radioactive iodine is contraindicated in pregnancy. In thyrotoxicosis, radioactive iodine plus anti-thyroid drugs are contraindicated. Proptosis, anti-thyroid drugs, and recurrence. Anti-thyroid drugs plus radioiodine further surgery carries lots of complications. Okay, let's revise first that what we have already discussed in the thyroid. First, we discuss the introduction, the arteries that are supplying the thyroid, then the synthesis of thyroid hormone, then what are the investigations options. Then we studied the thyroglossal cyst, its definition, then what are the clinical features. These are the midline swellings, move upward with swelling as well as protrusion of tongue, and unlike thyroid, which moves only with swelling. The treatment is cyst trunk operation. Then we study the goiter or thyrotoxicosis, what is the scenario and what are the clinical features in the scenario of goiter or thyrotoxicosis. That is, we have a patient of age 40 to 50 years and we are having multinodular goiter and swelling in the leg and loss of weight is present. Bowel mission is loose and there are tremors and heart rate is increased. Neck is smooth with moderate enlargement. So what are the causes or classifications of goiter? These are simple goiter and toxic goiter, hypothyroidism and neoplastic disease, inflammatory. These are the classification of the goiter. In the simple goiter, we are having diffuse and multinodular. In the toxic, we are having diffuse, multinodular, and toxic adenoma. In hypothyroidism, we are having usually multinodular. In neoplastic, we are having benign and malignant. In inflammatory, we are having autoimmune granulomatous, bacterial, and viral, and fibrosing. Okay, now coming towards the hyperthyroidism, that is thyrotoxicosis. Then we discuss its common causes. Then Graves' disease. Then what is the definition of Graves' disease? It is the most common cause of thyrotoxicosis. And what are the treatment options above 45 years and below 54 years? Then what is the toxic multinodular goiter and what are the clinical features of toxic multinodular goiter? Then what are the symptoms and what are the signs? Then what are the investigation options for toxic multinodular goiter? Then what is the treatment options and what are the patient prep for surgery? Then what are the complications? The complications then we have studied the three main different treatment options, that is surgery, radioactive iodine, and antithyroid drugs, and advantages and disadvantages of the each. Then we discuss the problems in treatment of thyrotoxicosis, the problem in pregnancy, in the thyrocardiac, and the prognosis and in the recurrence. Now we will study the next topic, that is thyroid tumors. Okay, now coming towards thyroid tumors, we are having a scenario that there is a patient of 18 years old boy having cervical lymphadenopathy on F5 needle aspiration from node revealed secondary from papillary carcinoma of thyroid. And then the another scenario is 40 years old painless lump in neck, and on examination lump is 3 to 3 centimeters smooth and fixed. Lump moves on swelling but not move on protrusion of tongue. So what are the investigations? What are the differential diagnosis? What are the classifications? The treatment, the complication, classify tumor of thyroid glands, then lump originate from and common type of malignancy and treatment, and what are the difference between papillary and follicular carcinoma and the treatment options. So thyroid tumors are the clinical features from which we will identify the diagnosis of thyroid tumors is that it will be solitary nodules and it will be hard fixed on palpation. Now coming towards the classification of thyroid tumors, there is benign and thyroid tumors, malignant thyroid tumors, and metastatic thyroid tumors. In benign thyroid tumors, we are having follicular adenoma, Hurthle cell adenoma, and colloid adenoma. In malignant classification, we are having papillary carcinoma 60%, follicular carcinoma 20%, anaplastic carcinoma 10%, medullary carcinoma 5%, malignant lymphoma 5%. Okay, in metastatic, we are having the kidney and breast. The spread is through lymphatics plus cervical lymph nodes and the papillary carcinoma, the follicular blood to the bones and then lung and then the liver. This is the spread of the thyroid tumor. Now, what are the clinical features? The clinical features are thyroid swelling is hard and fixed, hoarseness due to recurrent laryngeal nerve palsy is present, and cervical lymphadenopathy is present. In investigations, we will do the fine needle aspiration and the lobectomy or total thyroidectomy in doubtful conditions. Incisional or trend biopsy is done, true cut biopsy is done, and the CT and MRI is done to find the extent of tumor and lymph nodes involvement. Then we will do the radio iodine scanning and the ultrasound neck and the thyroid and autoantibodies are checked. Now coming towards the staging of thyroid tumors, we have TNM classification or staging, that is tumor, lymph nodes and metastasis. For T node, primary can't be assessment. For T node, no evidence of primary tumor. T1 is the limited to thyroid and 1 centimeter or less. The T2 is limited to thyroid or greater than 1 centimeter but less than 4 centimeter. The T3 is limited to thyroid and greater than 4 centimeter, and the T4 is extended beyond capsule of any size. In lymph nodes, Nx is equal to cannot be assessed, and 0 is no regional nodes or metastasis, and 1 is regional node or metastasis. In metastasis, M node is no metastasis and M1 is metastasis present. Now, stages under 45 years and stages over 45 years. So, stages under 45 years is stage 1 and 2. At stage 1, any T, any N, and M naught. In N2, any T, any N, or M1. Over 45 years, we are having T1 and not and M naught, then T2 and not M naught or T3, then N naught or M naught for stage 3. And for stage 4, we are having T4 and not M naught or any T, N1, M naught, any T, any N, or M1. This is the staging of the normal staging of the thyroid tumor. Now coming towards the papillary carcinoma and the follicular carcinoma. What is papillary carcinoma? It is more common, that is 60%, while follicular carcinoma is less common, that is 20%. Papillary carcinoma is more aggressive, while follicular carcinoma is less aggressive, while follicular carcinoma is more aggressive. Papillary carcinoma occurs at 20 to 40 years of age, while follicular carcinoma occurs at 30 to 50 years of age. Papillary carcinoma metastasis is to lymph nodes, and follicular carcinoma metastasis is up to bones. The papillary carcinoma spread is through lymphatics, while the follicular carcinoma spread is through blood into bones and lungs and liver. The papillary carcinoma cure rate is high, while the follicular carcinoma cure rate is high in young patients and decrease with age. In papillary carcinoma, histology typical papillary projects and empty nuclei are present, while in the follicular carcinoma, histology shows vascular and capsular invasion. What are the investigations for capillary carcinoma? These are fine needle aspirations, while the follicular carcinoma, we are having the investigation of frozen section. In the treatment for papillary carcinoma, stage 1 subtotal or total thyroidectomy is done. For step 2, functional leg dissection is done. For step 3, after surgery, thyroxine therapy is avoided till 4 weeks. In the follicular carcinoma, for stage 1 subtotal or total thyroidectomy is done, and for stage 2, radioiodine is done. So this was the thyroid tumor. Now, revising the thyroid tumor, what we discussed first, we studied the scenario, that what questions are asked, then what are the diagnostic points. These are the solitary nodules and hard fixed palpation. Then what are the investigation and classifications, the treatment, the complications, and the classification of thyroid gland, difference between papillary and follicular carcinoma, the differential diagnosis, the lump originate from, and the common types. Then the classification, we have benign, malignant, and metastatic. In benign, we are having follicular adenoma, Hürthle cell adenoma, and colloid adenoma. While in malignant, we are having papillary carcinoma, follicular carcinoma, anaplastic carcinoma, medullary carcinoma, and malignant lymphoma. In metastatic, we are having kidney and breast. The clinical features are thyroid swelling is hard and fixed, hoarseness is present due to recurrent laryngeal nerve palsy, and cervical lymphadenopathy is present. In investigations, we will do the following investigations. In this is the TNM staging, that is tumor, lymph nodes, and metastasis. Then the stage is under 45 years and over 45 years. Then we discuss the papillary carcinoma and the follicular carcinoma and the comparison between them, and what are the investigations and the treatment options for different stages. Okay. Now coming towards head and neck. What is acute parotiditis? The scenario is there is 18 years old patient, painful bulging swelling between mandible and mastoid process. Throbbing pain radiates to the air on examination, febrile with tender swelling which is reddish brown in color. So what is the diagnosis? What are the causative organisms? What are the predisposing factors, and what is the treatment? The causative factors of acute parotiditis are mumps, Coxsackie virus, bacterial infection, debilitating disease, Mycobacterium tuberculosis, and actinomyces. While the predisposing factors are reduction of flow of saliva following major surgical procedures, enteric fever following radiotherapy, obstruction to duct with retention of secretions. These are the causative organisms and the predisposing factors of the acute parotiditis. Now, what are the treatment options? We are having conservative treatment and surgical treatment. In conservative treatment, improves general condition of the patient, then antibiotic therapy should be started, soft diet is prescribed, general massage of the gland at regular interval to express pus. Now, in the surgical options, we are having incision and drainage if conservative treatment fails. So, what is acute parotiditis? We studied the scenario, then the cause to organisms and the predisposing factors, and then the treatment options, both the conservative and the surgical. Now, coming towards the pleomorphic adenoma, we are having a scenario in which there is a patient of 50 years old, 3 to 3 centimeter painless swelling is present on the lateral aspect of the skin of the neck, just below right ear lobe. Duration of swelling is 2 years, rapidly increasing last 2 months. So, the diagnosis, differential diagnosis, management, complications, causes, and investigations and treatment is asked. Okay, so what are the diagnostic points for the pleomorphic adenoma? These are painless lump in right parotid gland and painless lump in the angle of mandible. If these points are present in the scenario, then we will diagnose it as the case of pleomorphic adenoma. Parotid pleomorphic adenoma are the most common and benign tumors of the parotid gland. It involves superficial lobes of parotid gland, slow growing swelling over angle of mandible from many years. Raised air lobule are present. It is painless. Facial nerve are not involved. Swelling cannot be moved over the zygomatic bone. Now, what are the differential diagnoses? The differential diagnoses of pleomorphic adenoma are parotid carcinoma, lipoma, Sjogren syndrome, lymphoma, cystic lesions, and parotiditis. What are the management options? In management, we will take the history of the patient, take proper history of the swelling, whether it is firm, what is the duration, increasing or not, painless or not, what is the site, and what is the age. What are the investigations options? First of all, we will do the fine needle aspiration, that it helps in differentiated benign from malignant. Then we will do the CT scan and MRI for extent of tumor. Then we will do the excisional biopsy that is done when above ones don't indicate anything. Then treatment is done, that is superficial parotidectomy. Okay. What are the structures that are risk during the surgery? These are facial nerve, retromandibular vein, extra carotid artery, maxillary artery, postauricular artery, and superficial temporal vessels. These are the structures that are at risk during the surgery. Now, coming towards the parotid carcinoma, what are the differential diagnoses of parotid carcinoma? These are pleomorphic adenoma, acute parotiditis, malignant lymphoma, carcinoma, mucoepidermide, and cholelithiasis. What are the investigations? We will do the fine needle aspiration, the CT and MRI, the chest X-ray, and the excisional biopsy. What are the complications? Trismus, cosmetic deformity, and seroma are the complications. What are the treatment options for the parotid carcinoma? These are the radical parotidectomy with dissection of the nodes, conservative or total parotidectomy with dissection of nodes is done, and Fraser syndrome and infection. So, for parotid carcinoma, we are having a scenario that 55-year-old swelling on right side of face is present. On examination, swelling in front of right ear near angle of mandible, swelling warm, hot on palpation, and pain in swelling. Okay. Conservative total parotidectomy with dissection of nodes and Fraser syndrome infection. So, we have studied the we have studied the head and neck. In head and neck, we studied the acute parotiditis. What is the scenario for acute parotiditis, and what are the causes of organisms, and what are the predisposing factors? Then we discuss the treatment options, that is conservative and surgical. Then we discuss the scenario for pleomorphic adenoma. Then what are the diagnosis, the differential diagnosis, the management, complications, causes, and investigation. In the differential diagnosis, we are having parotid carcinoma, lipoma, Sjogren syndrome, lymphoma, and cystic lesions, and parotiditis. What are the structures that are the risk during risk? What are the structures that are at risk during the surgery, and what are the management options? Then we learn the management, that is, first we will take the history, then we will do the investigations, then the treatment. Then we study the parotid carcinoma, what are the differential diagnoses for it, and what are the investigations, complications, and treatment options. Now coming towards carcinoma of tongue. Okay, so carcinoma of tongue, we are having a scenario that is 20 years old, ulcer is present on lateral border of the tongue for 5 months. Look malignant on examination. No palpable lymph nodes are present. And what is the diagnosis? What are the risk factors? What is the assessment of the condition? What are the management options? And the lymphatic drainage and blood supply of the tongue, the investigation, the treatment, and the role of surgery in cancer. Now, what are the causes and risk factors for the carcinoma of tongue? What are the clinical features? Causes or risk factors, we are having tobacco smoking, pan chewing, alcohol intake, erythroplakia, hyperplastic candidiasis, ill-fitting denture. In clinical features, we are having the most common Presentation is growth may ulcerate or bleed, cervical lymphadenopathy, difficulty in swallowing, unexplained tooth mobility, trismus, reduced opening of jaws, and restricted tongue mobility. These are the clinical features of the carcinoma of tongue. How we will assess the patient? The assessment of the patient was first we will take the history of the patient, that is, ask patient about predisposing factors, then ask if ulcer is painful or not, then bleeds or not, ask about difficulty in mastication or swallowing. Then examine their oral cavity, examine for the type of ulcer, then examine to exclude metastatic signs. What are investigations options? First, we will do the final aspiration, then the incisional biopsy, then MRI is done, there is investigation of choice for oral cancer, and then X-ray is done, which is helpful for the assessment of bony incision of the tumor. Now, what is the blood supply of the tongue? The arterial supply is lingual artery, tonsillar branch of facial artery, ascending pharyngeal artery, and lingual veins. The vein supply is lingual vein. What is the lymphatic drainage of the tongue? These are to superior deep cervical lymph nodes, to inferior deep cervical lymph nodes, to submandibular lymph nodes, to submental lymph nodes. What are the treatment options? These are preliminary treatment, that is scaling and polishing of the teeth is done to establish oral hygiene. If necrotic or infected lesion is present, oral cavity is washed with hydrogen peroxide. If definite treatment, we will do the surgery and radiotherapy, which are equally effective in the treatment of oral cancers. For carcinoma of in situ, excision of the lesion with 1 cm margin about 0.5 cm deep is done. Lesion less than 2 cm, radiotherapy is done. If does not respond to radiotherapy, then surgical excision is done. If lesion is greater than 2 cm, then external beam irradiation of lesions and lymph nodes and excision of the lesion and lymph nodes is done. So what we have studied in the carcinoma of tongue, first we discussed the scenario that there is a 20 years old patient and ulcer is present on the lateral border of the tongue for 5 months. Then we discuss the causes and risk factors of the carcinoma of tongue and what are the clinical features. And then the assessment of the patient. First we will take the history, then examine the oral cavity, then we will investigate. The blood supply of the tongue is arterial supply, that is lingual artery, tonsillar branch of facial artery, and ascending pharyngeal artery. Then we discuss the lymphatic drainage of tongue. Then we discuss the treatment options, that is preliminary treatment, then the definitive treatment, then for the carcinoma in situ, and then for the lesion less than 2 cm, and then for the lesion greater than 2 cm. Now coming towards branchial cyst. Branchial cyst is also known as neck swelling. We are having a scenario that there is a young female presented with painless swelling on right side of neck. On examination, swelling is in posterior triangle of the neck near supraclavicular artery with slight discharge of pus. So the diagnosis, differential diagnosis, investigation and treatment is asked. In differential diagnosis, we are having lymph node enlargement, hematoma, branchial cyst, pharyngeal diverticulum, and cystic hygroma. In investigation, we are having the ultrasound or diagnostic, fine needle aspiration or sternomastoid contraction test is present. In the treatment option, we are having excision of test along with its entire epithelial lining. One must ensure that epithelial lining should be removed completely or else recurrence will occur. So this was the branchial cyst. What we discuss about branchial cyst? We discuss the scenario, then the diagnosis, the differential diagnosis, then what are the specific investigations that are done for branchial cyst, and then the different treatment options. In our next video, we will be discussing the orthopedic surgery. In this section, we have studied the whole thyroid. First, we have studied the introduction of thyroid, then we studied the thyroglossal cyst, then we studied the goiter or thyrotoxicosis, then the hyperthyroidism and thyrotoxicosis, the Graves' disease, the toxic multinodular goiter, then we studied the thyroid tumors, then the papillary carcinoma and follicular carcinoma difference, then we go to head and neck and studied acute parotiditis and pleomorphic adenoma, then parotid carcinoma, then the carcinoma of tongue, and then in the end we discuss a branchial cyst. In the next section, we will study the orthopedic surgery. Thank you.